Waldenström's macroglobulinemia is a lymphoplasmacytic lymphoma. This is a mature B-cell lymphoma that also has the ability to differentiate into plasma cells. So you see a combination of mature B cells, lymphoplasmacytic cells, and plasma cells in the bone marrow of a patient with this disease. And these are all clonally related cells. They all carry the same mutation. In almost all patients, it's the MYD88 mutation. So you'll see it in all the different cell types that make up the disease. Among the lymphoplasmacytic lymphomas, it's the most common. Almost 95% of them actually secrete IgM. So even though the word Waldenström's is almost synonymous with IgM lymphoplasmacytic lymphoma, it's important to keep in mind that there are other types of lymphoplasmacytic lymphomas also, IgG, IgA, and non-secreting as well. So the symptoms that patients present with Waldenström's can vary a lot, and that's why it's important to keep the symptoms in mind. For the typical patient, anemia is very important to keep in mind. There are many mechanisms under which the anemia can be produced. It can be because the disease has spread in the bone marrow and it's inhibiting the red blood cell producing cells from having space to be able to grow out red blood cells. It can be because of hemolytic anemia, where the antibody associated with the Waldenström's, the IgM, can bind to red blood cells and cause their destruction. But there's also this very interesting protein called hepcidin that's produced by both the tumor cells, but also in response to the interleukin-6 that's elevated in the bone marrow of patients with Waldenström. And hepcidin actually causes the loss of the ability to absorb iron by the gut. It also triggers whatever iron there is in the body to be sequestered in macrophages and monocytes. And so even if you stain a bone marrow to look for iron reserves, you'll think first off, well, there's iron there. But when you look very closely, that iron is in the monocytes and macrophages. And this can produce anemia. We see this a lot in patients with Waldenström. Sometimes we treat them with parenteral iron to overcome that gut blockade, and this can actually help the patients recover their hemoglobin very quickly. But it is an insidious mechanism by which patients can become anemic with Waldenström. Of course, there are other cytopenias too that can be produced because of the expansion of the tumor cells in the bone marrow. It's also important to keep in mind that in almost half of all patients, it's not because of tumor bulk in the bone marrow that they are symptomatic. It's because of the IgM. IgM is a big bulky molecule. It weighs almost 1 million Daltons, and almost 80%, 90% of the IgM that you and I make stays in the bloodstream. And as a result, it can have an undue effect on the viscosity of the blood. If you have too high of an IgM level, your serum viscosity can be high, and you can have all kinds of symptoms. Usually retinal bleeding is what we see. Nosebleeds can occur. So this represents an oncological emergency when you see it. In as well, the IgM can act as an autoantibody. It can attack the peripheral nerves. They're usually anti-demyelinating or demyelinating antibodies and strip away the insulation around peripheral nerves. So almost a quarter of the patients that we now see come in because they have peripheral neuropathy, diagnosed by the neurologists. Those are the people that are diagnosing Waldenström's now because they routinely get serum protein electrophoresis as part of their workup of patients with peripheral neuropathy. We also tend to see cold agglutinemia. We can see cryoglobulinemia because of the IgM antibody, as presenting reasons for why these patients get referred to us. Adenopathy, at least at presentation, is very rare. We only see it in about 15% of all cases. At time of relapse, it can be much more. It can be about half of all patients. So it's not as frequent a reason why we would initiate therapy, but it's important to keep in mind. And the last thing also to keep in mind is that sometimes patients can present with Waldenström's in the CNS, or they can relapse with Waldenström's in the CNS. It used to be a very rare occurrence that we saw CNS Waldenström's, which is referred to as Bing-Neill syndrome. But now we see 3 to 4, maybe even 5 cases a month in our clinic. It's becoming far more common. Maybe because we're also getting better at diagnosing it, but also because it's a sanctuary site that we see a lot of late relapses occurring.